Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today, I'm joined by Professor Douglas E. Wood, world-renowned thoracic surgeon and leader in lung cancer care. Dr. Wood is the Henry Harkins Professor and Chair at the Department of Surgery at the University of Washington in the very lovely city of Seattle, where he's played a pivotal role in advancing surgical innovation and cancer treatment. After earning his undergraduate and medical degrees from Harvard University, Dr. Wood completed his general and cardiothoracic surgery training at the Massachusetts General Hospital in Boston. With a career dedicated to thoracic oncology, he's led numerous national and international organizations, and he's currently president of the Thoracic Surgery Foundation and the Cardiothoracic Surgery Network. Beyond his academic achievements, Dr. Wood was a serious collegiate rower, winning gold medals in the Thames Challenge Cup just up the river from where I'm sitting, up at the Henley Royal Regatta, which is coming up soon, and the US National Championships. Staying true to his passion for, shall we say, nautical adventures, he also worked as a ship's physician on the Society Explorer in Antarctica, which sadly sunk in 2007. He and his wife were married by a captain on a ship called the World Discoverer, theme coming up here, which later shipwrecked in the Solomon Islands in the year 2000. Welcome to the podcast, Professor, or should I say, Admiral Douglas E. Wood. It's a real pleasure to have you here.
Well, thank you, Jonathan. And you're funny to know those details about my background. And yes, it is a little embarrassing to say that the two ships that I spent some months on in Antarctica both are at the bottom of the ocean. So I hope that doesn't portend any negatives of spending time with me on a boat. I have had some success on a boat, just smaller boats. It's the big boats that I have trouble with.
Yeah, well, I was going to say actually, I'm a keen sailor, and I'm given the fact that you've seen two go to Davy Jones' locker, I'm not sure I'd want to get on a boat with you. But you clearly embrace life in all ways. Tell us what shaped you and led you into the career that you have.
Yeah, thank you, Jonathan. As I look at my life, my career, I've really been very fortunate and privileged. And I'll say that my sister and I grew up on a farm in Michigan, and we're actually each first generation to attend university in our family. Our parents did not have the type of opportunities that she and I had. But I look at my parents, and they were very smart and placed a high value on education. Um, but also growing up on a farm with stoic Midwestern parents, they imparted a strong work ethic, an expectation of excellence, a commitment to high ideals of integrity, um, and a respect for others. And I think that has shaped a lot of who I am. I think to represent how they raised me. And amazingly, with limited experiences that they had, they supported me in bold and sometimes cockamamie ideas of what I wanted to do for my own education and my own approach to life.
Mhm.
And I developed this life philosophy to live boldly and love deeply. And that's been my mantra through life. And you mentioned my rowing team that was successful at Henley. Our theme song was "Take It to the Limit" from by the Eagles, and that's how we defined how we approached a race, and that's largely defined how I've approached my life. I've been fortunate to have partners, mentors, sponsors who have opened doors. They've provided sage advice, they've tolerated me, they've corrected me, they've forgiven me for my mistakes. And I really have enormous gratitude for these people in my life, beginning with my parents, who pushed me and lifted me and have been kind with me.
Well,
And really, that's the reason I think I've been afforded so many opportunities.
it's interesting that you were a rower because I think of all the sports, certainly any team sport. I think what's that tired old expression? There's no I in team, but I was a rower as well. I was not as good as you, but yeah, I was recently walking along the River Thames in the upper reaches around Henley, and I was watching a lot of boats out on the river practicing. It is so apparent in an eight, especially one person who is out of beat, out of order, can screw the whole thing up royally. And I think learning how to be part of a team. And I think the lay public has a perverse perspective of what it is to be a surgeon, and certainly, to do bold things like cracking chests or drilling holes in people's heads. With I can't think of a thoracic surgeon or a neurosurgeon I've met who was imperious, pompous, narcissistic. They all tend to be very, very thoughtful individuals and team players. Is that a fair characterization?
Well, it's a kind characterization. I think that I have met surgeons who are pompous and narcissistic and are difficult, but I think that the vast majority have great humility about the privilege of what we do and the privilege to to do something that matters for people. That I think of this frequently, and when I'm having a tough day, I think about it. And the privilege to do work that that changes people's lives, that actually, day in and day out, helps people to live longer and live better. And when I think about the opportunity to do that, I have gratitude and feel privileged that my patients trust me to care for them and to, as a surgeon, invade their body and do something to try to heal them and make them better.
Yeah. Well, with that, let's dig into some of the things you've been involved in. So, your work in thoracic oncology has been groundbreaking, from pioneering surgical techniques to shaping national lung cancer guidelines. Can you identify two or three of the improvements that you've been involved with that have given you the most personal satisfaction?
Yeah, Jonathan, I think most of the people in the audience probably recognize that lung cancer is by far the most common cause of cancer mortality, certainly in the United States and the Western world, but really globally. Um, in fact, more people die of lung cancer than die of breast, colon, pancreatic, and prostate cancer combined. And I think often we're surprised when we recognize what really a public health problem lung cancer is. And when I think about my career, I think there's maybe three things or three parts of my career that have had different aspects of focus on improving outcomes from lung cancer. In my early career, it related to really surgical advances and advances in technique, particularly for individuals with locally advanced lung cancer, often that were considered unresectable. And I had the benefit of tremendous surgical training from Dr. Hermes Grillo and Dr. Doug Mathieson. Um, and that training gave me the confidence and experience to take on some pretty complex surgical operations for curative intent. And of course, I wasn't the only surgeon doing this. Many other of my colleagues were leading innovations as well. But this was an area that was an important part of my early career. The second aspect has been involvement in standardization of workup, staging, management of lung cancer, really through national guidelines development. And I've served on the National Comprehensive Cancer Network, or NCCN, lung cancer guidelines nearly from their inception. Um, and I've had a long commitment to the importance of meticulous staging combined with standardized management, of course, while continuing to respect the need for personalized and individualized care. And I would even say one of my former mentees in this area has taken it far beyond anything that I've done myself. And is now one of my partners. And probably we have a role reversal now of me being more the mentee and learning from my younger colleague. But the last one, I think, is the biggest one. And this area of my career that I stumbled onto, but has ended up being probably most impactful, is the development of guidelines and influence of healthcare policy around lung cancer screening. Um, Lung cancer screening is a critical aspect of early detection for lung cancer and really the most powerful tool that we have for changing lung cancer victims to lung cancer survivors. And I was fortunate to be asked to chair the inaugural NCCN lung cancer screening guidelines panel that published the first guidelines about lung cancer screening, um, and that recommended low dose CT for lung cancer early detection.
Well, let's dig into that a little bit because thank you very much. It's like, when they say in the stage show, we haven't met before, have have we? But it's a perfect setup because I was going to ask you about the role that you've played in shaping lung cancer guidelines. And I should throw out there, my late father died of lung cancer. He was a heavy smoker, and
Sorry.
I visited his grave recently, and I was thinking about how things have changed in the 26 odd years since he passed, dramatically. What are the most important recommendations for clinical practice that those listening, they may not know all the guidelines? What are the important recommendations about who should be screened, how they should be screened, and how they are evolving?
Yes. So lung cancer screening only became implemented as a covered benefit in the United States 10 years ago. I mean, it's new. By covered benefit, I mean in our health system in the US that somebody will pay for it. And this was considered by some to be controversial, and some individuals felt we should really restrict access to lung cancer screening to your question of who's eligible for it. And 14 years ago, when we published the first guidelines, we recommended screening individuals older than age 50 that had a smoking exposure of 20 pack years or more. 10 years ago, when coverage decisions were made, the restrictions were much, that were the inclusion criteria were much more restrictive. And fortunately, they've now evolved. So those guidelines and coverage have now become much more aligned with what we originally said in the NCCN guidelines, meaning um, in the United States, insurance now covers lung cancer screening for individuals 50 to 80 years of age with 20 pack years of smoking or more. And one key thing that um, we're still working on is if you've stopped smoking, it has to have been within 15 years, meaning if you stop smoking for more than 15 years, you're no longer eligible for screening. And other countries that have screening programs have some variations of these recommendations. Some are more restrictive than the United States, but that at least gives you an outline of what we have approved and what we're doing in the US.
Right, right. Well, I mean, I know that I'm harking back. Oh, good Lord, longer than that, early 1990s, and I had a cardiac CT, just because one of my colleagues was involved in introducing cardiac CT screening, and he encouraged me to get it, so I got it, and I was very happy that I had a calcium score of zip. However, they saw a lung nodule, and I immediately went and talked to my colleagues, one of whom told me I should have a bronchoscopy immediately. And I'm looking at this thing, and it's right next to a bloody great big vessel. my thoracic colleague wanted to, quote, whack out that bit of lung. And I'm a keen scuba diver and runner and such like. And I thought, yeah, no, that we're not going there. So I ended up just having sequential CTs, and eventually they said, yeah, it's not changing. You're fine. But I'm just it's I know people rail against guidelines, and yes, of course, we need to personalize medicine, but big data and AI are going to enable us to better interpret who should receive these screening tests and what they mean, right?
Mhm. Yeah, absolutely. And what you just described is a concern about lung cancer screening. I think it's easy for individuals to feel like, what's the harm of getting a CT scan for lung cancer screening? We ought to do it for everyone. But there is a harm. You just described what that potential harm was for you, is identifying things that are unimportant, and and the downstream consequences of that, which for you could have been a surgery with consequences that fortunately you were smart enough to avoid. But it is correct to be cautious about implementing screening, because essentially when we do that, we are taking healthy individuals, not patients, not somebody that's ill, and subjecting them to a test that for some will save their lives and for others will harm them because they'll have a biopsy or a surgery that is unnecessary. And AI is going to help us with that. I think that's what you ask. And I think that um, our technology continues to give us ever improving ability to first identify the right people for screening, and then second, to evaluate the results of that screening so that we take care of the people that actually have a cancer, and we try to leave alone the people that don't.
Yeah. So, what are the next steps in expanding lung cancer screening? Are there like next groups that the data suggest we ought to be screening?
Yeah, I think that um, screening right now is limited to the age group that I mentioned, and to those that have a significant exposure to smoking. Um, and and the benefit, of course, is trying to move people from late stage detection of cancer to early stage when we can treat them more effectively. Um, One group that is increasingly recognized is a group that are never smokers that have lung cancer. And I think many people think, well, you have to have smoke to get lung cancer, and that's not true. The only thing that you have to be at risk for lung cancer is lungs, and we all have those. And there's particular demographic groups, for example, Asian women, that were increasingly recognized without any exposure to smoking, um, have a risk of getting lung cancer. And I think one of the challenges that we have is, how do we find those cancers, the cancers that are um, important but not presenting in this typical pattern of somebody that's older and with a smoking history. Uh, that I think is an area that so far we have not figured out, that we've not made progress in. And beyond this narrow group of people that I just defined earlier, who else ought to get screened for lung cancer, and how can we do that effectively?
Yeah. And obviously, there are constraints on the service constraints, cost constraints on both sides of the Atlantic. Very much so. So, Doug, I was very privileged to be involved in the early days of minimally invasive and robotic surgery. In your field, VATS, video assisted thoracic surgery, has revolutionized lung cancer treatment landscape. How have these innovations improved patient outcomes, and where do these technologies take you next?
Yes, you're right. And I think that general surgeons developing laparoscopic techniques fairly quickly evolved to thoracic surgeons using the same scopes and equipment to do minimally invasive surgery in the chest. And um, now, minimally invasive surgery, both video assisted and robotic assisted, have been truly um, uh, making changes for patient outcomes and have been an incredible advance in lung cancer care over the past couple of decades. For many patients, these minimally invasive techniques allow surgical removal of lung cancer with a shorter time in the hospital, shorter recovery, and minimizing the negative consequences of surgery. And I want to say there's still a very important role for open surgery. We have patients with larger lung cancers, more complex anatomy, particularly central to the hilum. Um, so minimally invasive surgery has been critical, but it doesn't replace all open surgery. Um, but another advance has been a recognition that we can remove smaller amounts of lung and still have good cancer outcomes. And that's actually been pretty recent because historically, um, we had data from the 1980s, 1990s that you had to remove a whole lobe of the lung as an adequate cancer operation for anybody that had lung cancer. But now we recognize that patients with smaller tumors near the periphery of the lung can have just as good, maybe even better cancer outcome with a smaller removal of lung. We call them sublobar resections, removing a wedge of lung or a segment of lung instead of a whole lobe. And this has also been an incredible advance in helping patients tolerate surgery and have better quality of life after surgery. And we're going to continue to evolve the limits of what we can do. There's other aspects of how many lymph nodes we remove. We have guidelines that say we have to remove this pattern of lymph nodes anytime we're doing lung cancer surgery. And actually, we're recognizing there are some patients that are really at very low risk of lymph node involvement. And we probably can identify a, a group of patients that don't need that aspect of surgery either. And I guess the last point I'll make is I see patients that I'm pretty sure have lung cancer, but they're very indolent. And I have a discussion with the patient, and we make active decisions to not operate, meaning we are willing to observe because that cancer may never be something that affects their life.
Yeah. I mean, the same thing has transpired in prostate.
Mm.
Has it, of course, where the active surveillance, which is a fancy way of saying we're not going to do anything. I mean, I'm being a little bit flippant here.
And we
Um,
never would have considered that for lung cancer. We always said as soon if we see a lung cancer like
the
the
disease.
nodule that was seen in you, the
Yeah.
view was we have to whack it out.
Yeah. Yeah.
And now we're more nuanced and we're a little smarter about that. And not everything needs to have an operation.
So again, the advances in your field, Doug, with the evolution of targeted therapies. I've recently been reading about targeted alpha therapies with actinium, as well as the new chemotherapeutics, immunotherapy. Um, the role of the multidisciplinary team has always been an important consideration. I know when it started, it always struck me that it was a little bit of a turf battle.
Mm.
This is this should be with me. That no, this should be with me. Now there's much more of a collaborative approach. That's going to happen more and more, isn't it? As knowledge evolves about the nature of lung cancer on an individual patient basis.
Yeah, you're right. I think our multidisciplinary teams are increasingly important in our care for lung cancer. I've been fortunate in my career that here at the University of Washington, we've had a really collaborative multidisciplinary environment for my whole career here, meaning the medical oncologists and radiation oncologists and thoracic surgeons and pulmonary physicians. We're tightly linked, and I feel there's very little turf battles between us. We're working together to do what's best for the patient. And as you said, we're in a time, I want to emphasize that we're in a time of rapid progress in systemic therapies for lung cancer. You mentioned targeted therapies, immunotherapy. They're they're game changers in changing the prognosis of patients with advanced lung cancer. I now have seen patients and colleagues that in some of my um, cancer groups nationally who are 10, 15, or more years survivors from stage 4 lung cancer.
One
Um,
you'd
and
never have
interestingly, yeah, go ahead.
I was just gonna say one would never have dreamed of that.
Exactly. I mean, that was, you know, historically, just the label of lung cancer was felt to be a terminal label.
Yeah.
Uh, and um, and getting people to recognize the incredibly the changing outcomes of lung cancer is important. And yet, some have brought up that maybe the role of surgery will be less in this era of systemic therapies. And I'm going to say, Jonathan, frankly, I think the impact is the opposite. I think this expands the role of surgery for local control when it's combined with improved systemic therapies. You know, patients that we never would have considered for surgery because of it, lymph node disease or metastatic disease, that disease is sometimes being sterilized by the improved systemic therapies, yet the primary cancer in the lung still needs a local therapy. And that's a place where in this multidisciplinary management that you talked about, that the medical oncologist will call me and say, this patient with advanced stage 3 or even stage 4 disease, we want you to consider surgery because the only thing that's still active is the cancer in the lung.
Mm.
And so this multidisciplinary management that you said is more important than ever.
So it would be fair to say, Doug, that our thinking about lung cancer staging has evolved dramatically, and that's got a direct implication into um, treatment planning, so defining who is and who is not a surgical candidate. What are some of the other key considerations? Because I never would have guessed that stage 4 lung cancer patients would be candidates for a surgical resection.
Yeah, I'm going to make, yeah, I'm glad you brought up staging. Staging is, well, as I said earlier in this discussion, kind of one of the phases of my career was really focused on this aspect of lung cancer staging. You know, of course, staging determines how we choose a treatment for a patient and a prognosis for a patient, what their therapeutic options are. And of course, we want to get it exactly right, but we're not perfect. So we might either understage somebody or overstage someone. And and when we understage, we might miss an opportunity to treat someone with the optimal therapy. But I want to really emphasize the problem of overstaging a patient, which you'd like to think it's rare. It's not rare, where we actually think they have more advanced cancer than they do. And this is a place where I've had a mantra in lung cancer care to give the patient the benefit of the doubt rather than the tumor when there's any area of uncertainty, and that we really need to prove an advanced stage by biopsy or advanced imaging so that we don't miss the opportunity to treat patients with surgery or other curative intent therapy. So that's one aspect of choosing patients for surgery. And the other major one is just their medical fitness for surgery. And that requires a careful assessment of the whole patient that is very personalized. Looks at their medical conditions, their pulmonary function, their level of frailty, um, and how much lung are we going to remove? How big is the operation going to be? And evaluate and then have a shared decision making discussion with the patient about weighing the benefits and risks of surgery. And I guess I'll just add that as surgeons, we also need to know when not to do surgery. Um, Sometimes we have to recognize when an alternative to surgery, like radiation, may be a better option for patient and allow them to be treated more safely.
One of my mentors, Doug, had a great expression. Um, we spend many years learning how to operate. We spend many years learning when to operate. Perhaps we should spend many more years learning when not to operate, and doing it, as you say, in a collaborative manner with the patient. And that requires a different skill set. Um, I want to switch up the discussion a little bit, because my dad, bless him, also had emphysema, COPD, big smoker, and I discussed lung volume reduction surgery with him. It was becoming all the rage back then. He didn't want to go with it. But a three-parter for you. What are the current guidelines for the procedure? We know that smoking and other pulmonary irritants are causative, but what role does alpha one antitrypsin deficiency play? And finally, is the jury still out on the damage that vaping might do to the lung? It pisses me off walking along the streets of London or anywhere else, and I'm enveloped in these sort of sweet smelling strawberry clouds. I'm thinking, I hold my breath because I'm thinking, oh God, what's this going to do to my lungs? So, three-part question for you, Doug.
I hold my breath also, but these days I also have to hold my breath for the smell of marijuana smoke when I walk down the street as well.
Yeah.
So,
Mind
yeah,
you,
I'm glad you brought up.
if you don't hold your breath, you'll have to pop into a convenience store and buy a packet of Doritos.
Well, yeah, I sometimes laugh with my wife, and as I walk by, I go, big breath going by. um, I'm glad you brought up lung volume reduction surgery. That's a part of my career separate from lung cancer. I was one of the primary investigators for the landmark National Emphysema Treatment Trial that actually clarified the role of lung volume reduction surgery for certain patients with end stage emphysema. And you ask who's a candidate for that, and I'll be quite specific. The criteria for that are uh, emphysema with uh, very low FEV1. We look at individuals less than 45% predicted FEV1. They also have to have marked hyperinflation, eh, as measured by the total lung volume or residual volume. We're often seeing residual volumes of 250% predicted, 300% predicted. Um, Generally, I'm looking for people that have at least more than 175% predicted residual volume. For lung volume reduction surgery, it also needs to have a certain pattern of emphysema that is heterogeneous upper lobe predominant. So, those are all the characteristics for lung volume reduction surgery. I'm sure you're aware that after we developed lung volume reduction surgery, we developed alternatives to that, which is bronchoscopic lung volume reduction, putting valves in the airways to try to achieve some of the same uh, aspects of lung reduction surgery, but without the operation. And we actually can have a broader selection criteria for many of those patients. And you brought up alpha 1 antitrypsin deficiency as a cause for emphysema different than smoking exposure. Those patients typically have lower lobe predominant emphysema, so are less likely to be eligible for lung volume reduction surgery, but are eligible for endobronchial valve placement for bronchoscopic lung volume reduction. And then your point about vaping, I wish I do the answer. I don't know the long term impact of vaping on lung parenchyma, but I'll tell you, I'm certainly suspicious that the long term effects of a caustic inhalational agent is likely going to cause long term and permanent lung damage.
Yeah, yeah. I I say that to the kids I know who do this stuff, and I understand getting off cigarettes, but you know there are kids who are taking up vaping who didn't smoke, and yeah. Anyway, thank you for that. So let's go back to lung cancer. The future of lung cancer has been evolving constantly. What current clinical trials, surgical innovations, or policy initiatives particularly have you excited? Before we were recording, you told me that your daughter lives in London and you're going to be over here. As you probably know that in the UK, the new initiatives are going to make it impossible for people currently aged 15 or under to ever buy cigarettes, which I personally celebrate. And you know, they banned them in clubs and pubs. Yeah, a lot of pubs went broke, but I now actually enjoy going into the pub to have a drink or going into a jazz club and not, you know, hating the smell. What are your thoughts on all of those things at or just over the horizon? And what else can we do from a policy perspective?
Yeah, great question, Jonathan. And I guess I'd start off by saying there's never been a more exciting time to be a clinician or researcher dedicated to lung cancer. Early detection that we talked about earlier, and the rapid changes in management and surgery, radiation therapy, systemic therapy are revolutionizing the ability for us to care for people better and for have our patients live longer. And I'm most enthusiastic, maybe I'm biased about this because it's the area that I'm involved in early detection. And you ask what's evolving. It is a rapidly evolving field there, from um, different techniques of early detection. I mentioned low dose CT. That's what we use now. But um, using radiomics, how AI evaluates a CT scan, using evaluating fragments of cancer DNA within the bloodstream, even exhaled breath, as as has possibility of a different way of early detection from a CT scan. And so it, these are going to continue to evolve and not eliminate CT scan, but be a complement to CT scan that allows us to select people better and minimize how many times people are getting radiation from imaging. So you brought up this aspect of a proposed law in the UK about not allowing anyone over that was born after a certain age. I think it's 2009. In the UK to not be able to buy cigarettes. And um, I was first aware of this. New Zealand actually was the first country that did this, and they've reversed it. 2 years ago, they reversed that policy, and I'm going to be very interested to see if it actually proceeds in the UK. And I have to say, my instincts are the same as yours to applaud this aspect of limiting access to cigarettes. But I'm going to bring up a different point. It it's very interesting to think about um, whether this is a challenge to some of our principles of freedom, including our freedom to pursue vices that harm us. And it can seem contradictory to some of the other things that we do. For example, I talked about marijuana. We have legalization of marijuana. We're going the other direction there, which also has adverse health effects. And so I, I'm of a mixed mind. As a lung cancer doctor, getting rid of cigarettes is great. In principles uh, of freedom and equity of how we handle other vices, I'm not sure that those policies are the best way to accomplish it. We have been very effective. I'm going to talk about United States statistics. In the past 50 years, we've decreased smoking rates by 73%. in the United States, and it's now under 12%. And for young people, even more. It's under 4%. So our education to try to have people stop smoking and recognize the health effects have been successful. We'd like it to be more successful.
Yeah. I think probably there's a balance, isn't there? What is the damage to our population? What is the cost to our population of smoking? And then, drum roll, please, what tax revenues does this puppy produce?
Yes, yeah.
What
There
we
are lots of secondary agendas that are going on. You're right.
and I know I've always loved the American approach to preservation of freedoms. Well, yeah, but then let's remove barriers on roads with high drop-offs. Let's remove any safety barriers. But anyway, that's another conversation. Doug, a final question I love to ask people: if a magical genie popped up and you live in a particularly magical part of the world, I love your city. If a magic genie were to grant you three wishes for healthcare, your area of healthcare, what might those wishes be?
Wow. Um, I'd really like to have that magical genie that you're talking about. Um, the one I'm going to pick first is, I think, easy, and I hope that everyone says it. In We have different health systems. Obviously, I know the UK system well. Uh, very different uh, access um, and and rights from the United States. And my first would be access and equity for people, that people can access the health care that they need and when they need it. And a nationalized health system has problems with that in terms of waiting lists, and a non-nationalized health system like the United States has problems because of people without insurance. And both provide some aspect of inequity and lack of being able to get the care that we need. The second one I'm going to bring up, I think I wouldn't have thought of a few years ago, but it's about a continued respect for the science of healthcare, because it seems to me that that respect has been eroded and is eroding. And in the advances, vaccines, et cetera, that save lives, and get the politics out of science, the politics, religious, whatever other factors are making people question science. I'd like to bring the trust back about science for the public. And my third wish is to get rid of the bureaucracy of healthcare and simplify the physician patient connection that surgeons and physicians a generation before us enjoyed, with simple notes, you know, uh, not complex billing, not a bunch of administrative hurdles, not compliance modules to accomplish, and a lot of things that get in the way of the doctor and the patient and how they work together for patient care.
Yeah.
So uh, those would be my three wishes if I get wishes for the improvement of healthcare.
Yeah, I'm with you on all of those, and I've spent half my life in the United States practicing, and I cannot wrap my head around the vitriol that's directed at the British healthcare system by some Americans, and I cannot stand the vitriol that's directed by the American healthcare system by some of my British colleagues. How's about we all get in a room and say, you know what, I ran my practice in America with minimal administrative interference. It was me and my secretary. Actually, it was my secretary. I worked for her. She was the boss. And Linda, if you're listening out there, bless you, we just got stuff scheduled and got stuff done, and we were providing a service to human beings in distress, and it was the biggest privilege of my life to do that. No administrator getting in the way and telling me how to look after my patient. It was
Right.
my responsibility to do that. I wish we could all get in a room and say, you know what, you Americans do this very well. You British do that very well. Why don't we adopt what we do well and move on? Well,
I'm
it's
with you. Yeah.
absolute delight talking to you. Maybe one of these days we'll be able to go. Are you familiar with the book by Jerome K. Jerome, Three Men in a Boat?
I am familiar with it, but I've not read that one.
Read it. It's a lovely,
Okay.
lovely book about a simpler time where three men and a dog named Montmorency go on a rowing trip up the Thames. They also made it into a made for TV movie with Eric Idle and Tim Curry, as I recall, in the many years ago. Fantastic watch, but for a rowing man, you would love it. Doug,
And I hope you've read Boys in the Boat.
oh yes, actually I did. It was recommended to me by a dear friend. I did, absolutely.
Yeah,
Absolutely.
the boathouse of Boys in the Boat is just about 300 meters from where I'm sitting right now.
Oh, that's fantastic.
Yeah.
Absolutely fantastic. All right. Well, folks listening in, I don't know if you've learned anything about medicine. If you haven't, you weren't listening, but you've certainly got a couple of book recommendations from the EMJ Book Club. I'm afraid that's all we've got time for today. I'd like to thank Professor Douglas E. Wood for his time, for his grace, his humility, and his wisdom, and frankly, for everything you're doing for patients like my late dad who have lung cancer. Real pleasure chatting with you, Doug.
Thank you very much, Jonathan.
So, folks, as I say, you've got some book recommendations. Hopefully, it gives you an inspiration to subscribe for the podcast, and you can leave reviews, like us, tell your colleagues, blah blah blah. You know the drill. Check out the archives. There's several hundred episodes in there. I'm such a lucky guy. I get to meet and talk to all these brilliant people. And please join us next week for another fascinating episode. Until then, I'm Jonathan Sackier. I thank you for listening to the EMJ podcast. Please, everyone, stay safe. Stay well. Stay curious. Bye for now.